My name is Dr. Meredith Warner, and I'm an orthopedic surgeon here in Baton Rouge, Louisiana, and I also work in New Orleans where I teach for LSU Orthopedics. And I run a wellness practice focused on wellness, but obviously we also do orthopedic surgery and treat orthopedic conditions. But my main goal is to help people really actually get better and actually be happier and healthier and actually live better lives rather than just doing procedures and doing injections for the heck of it. And so we're going to talk about knee arthritis today specifically and the different ways you can treat that and sort of my preference, which certainly isn't every surgeon's preference, but I'll tell you all the different alternatives. And we'll talk mostly about rheumatoid arthritis and osteoarthritis. Okay. So in this clinic, Warner Orthopedics and Wellness, which is right where Behringer Foreman crosses Airline, it's our new building. We just moved in like 4 or 5 months ago. We love it. In this building, we are able to fulfill the mission that I've sort of had a vision for 6 years. I wanted a beautiful environment that promotes health and wellness, nice and clean, pretty well lit, daylight spectrum only, fully equipped, state of the art to be able to provide things like aesthetics, massage therapy. We're going to have an infrared spa. We've got highly trained physical therapists. We have myself, I have a podiatry partner. I have a physiatrist partner, which is sort of non-operative orthopedics. And she does things like nerve conduction studies and Botox for migraines and spasticity and things like that. And basically we promote natural healing, self-empowerment, trying to get better on your own, using your own skill sets and your own body's power. That's my goal for you. And there's a very strong body of evidence behind alternative and natural medicines, which we believe in. Obviously, we still perform surgery and obviously we still prescribe medicines, but I just want you to know that you do have an alternative out there from the big box medicine that is really all that's available in this country at this time. Next slide. Okay, this is our clinic, as you can see, and we have a beautiful big gym with everything that we need to be able to get people well, and we can convert it into a yoga studio when we do yoga for our patients, and that's my personal favorite modality for treating many musculoskeletal complaints. The bottom left corner is my podiatry partner, Dr. Lindo, and he's just an awesome guy, and I think everyone will love him. And then the bottom right is a couple of my medical assistants, and a brief bit about my team. It's taken a long time to put this team together, but everybody involved is really, really invested in your health and wellness too, and we're sort of all on the same page with that. All right, so we are about to start talking about knee arthritis, which is unfortunately very, very common. Okay. A primer on arthritis. What is arthritis? So itis in Latin basically means inflamed. So if you ever have a word that ends in itis, that means inflammation of. Arth is the Latin stem for anything to do with the joint. So this is inflammation of a joint, okay? So like arthrodial is of the joint. Arthritis is inflammation of the joint. And why do you get inflammation? Well, infection, injury, those are what we commonly think of as causing inflammation, but really it's environmental toxins, the water we drink, the air we breathe. Stress can cause arthritis by increasing levels of inflammation. Diet certainly is an issue. And in fact, we're now coming to understand in this country that diet and lifestyle is really the #1 cause of chronic, debilitating, non-hereditary conditions such as diabetes, arthritis, etc. What happens with arthritis and what's the real problem? I mean, if you had no symptoms, no one would care, right? But you get pain and swelling, and then ultimately the pain and swelling will lead to limits in motion. When you have limits in motion, you then have impairment or movement disorders. And then that can eventually result in pain. And unfortunately, an impaired knee can also damage your hip, your low back, your ankle. So everything's sort of connected through these long lines of fascia. The human body is really a beautiful machine that was designed perfectly. And when one little thing goes awry, you begin to compensate and develop problems elsewhere. That's sort of our specialty. We can see those and correct them for you. Arthritis can affect any joint. What is a joint? A joint is merely 2 bones that move against each other, and each bone has a coating on it. And the coating here would be the bottom of the thigh bone or the femur and the top of the shin bone or the tibia. That coating is cartilage. Cartilage is an extremely low friction surface that allows smooth movement of 2 bones to let you move in space. So your shoulder can be affected, your elbow, all of your fingers, your wrists, anything in your neck. Really anywhere that you move, even your jaw, temporomandibular joint can become affected by arthritis. And then spurs, which the right side picture shows you that. So a lot of people will have spurs form first at these joints, out in the outside of their fingers. That's traditional arthritis. Rheumatoid arthritis affects joints closer to the wrist. What the body does when there's abnormal motion and instability is it will grow a spur. The spur increases the surface area and is sort of a bony response to abnormal forces, and it's your body's way of trying to compensate and sort of make you able to accommodate for the impairment that the arthritis caused. So in general, that's what arthritis is. It's inflammation from a variety of sources to the beautiful, smooth, cartilaginous surface of any joint, and that will lead to pain, swelling, movement disorders. So arthritis in this country, and really in most Western countries, is a leading cause of disability. Now, disability is different than an impairment, of course. You can have an impairment but have no disability. It's when an impairment sort of limits your activities of daily living or your ability to work that we then drop you into the category of being quote unquote disabled. But just because you have arthritis and an impairment doesn't mean that you have to be disabled and vice versa. These two slides are from CMS, and they're large-scale data drops from the Medicare data and really from all of the various federal data gathering groups. They produce these maps that sort of pictorially show you how bad this problem really is. And if you look at Louisiana, we're at the high end on both arthritis attributable work disability, meaning that in Louisiana, more people are disabled by their arthritis than, say, in Texas or where I'm from in Delaware. And then on the right side, you can see that the prevalence of arthritis is also higher in Louisiana than, say, Texas or Delaware. Well, Delaware actually looks pretty bad there, doesn't it? But Texas, so you can see how you can look at these maps and kind of get an idea of where you fall in terms of your geography. And this can be from a variety of sources. We know that Louisiana is traditionally 48th, 49th, or 50th in all healthcare parameters. So we're very high in the chronic inflammatory load, lifestyle disease load. About 30 to 40% of our population is diabetic. 30 to 40% are obese. So you can kind of almost guess we would have higher arthritis and higher disability rates. One of our goals is to help the community become healthier and treat these chronic inflammatory conditions and make this better. Next slide. So types of arthritis. There isn't just arthritis. There's a bunch of different arthritises. The right side shows you on the right picture on the right side is a healthy knee. And what you want to look at is that top sort of light gray shadow is the thigh bone, okay, the femur, with the kneecap superimposed. And the bottom is the tibia with the fibula, okay? And that space between shows you where the meniscus and the cartilage live. And you should have a certain amount of space, and this has been measured and studied. So we know for certain ages what number of millimeters is considered normal. And if you look on the left side picture, you can see on the inside part of the knee, the medial compartment, obviously that's not good. And it's almost what we call bone on bone, where there's literally no space there. So the types of arthritis: osteoarthritis, which is the most common, rheumatoid arthritis, psoriatic arthritis related to psoriasis. Mickelson, the famous golfer, has psoriatic arthritis, and obviously, although he has the condition, it is not disabling to him. Infectious arthritis, juvenile arthritis, gout, very common in areas where there's a high prevalence of eating red meat and things like that. Spondyloarthropathies, which is like, it's sort of a genetic condition where you form massive spurs and you have significantly inflamed joints, and anywhere where a tendon attaches, you'll get a spur and pain. Lupus can cause arthritis, and then post-traumatic. To get post-traumatic arthritis or arthritis after an injury, you actually have to crack and fracture through cartilage or have a massive impact to the cartilage. Ankle arthritis, 80% of ankle arthritis is post-traumatic in nature, whereas only about 20 to 40% of knee arthritis is. Most knee arthritis is genetic, or we used to think genetic, but probably lifestyle-based. Here's some pictographs also from different sources, CDC and others, showing you the burden of arthritis in this country and sort of what we as physicians, and particularly orthopedic surgeons, because we deal with bones, muscles, tendons, ligaments, joints, and spinal problems. 27 million adults are affected with this. And if you think about a country of 360 million, that's a pretty high burden. More women than men are affected by arthritis. And arthritis increases in prevalence as we age. So the bottom right on the left picture shows you that about a third of adults can be expected to have some type of issue with arthritis at 65, and that just keeps increasing as you get older. Half of the people visit their doctor 2 to 4 times a year for symptoms related to arthritis. You can see it's sort of a big burden in terms of healthcare and healthcare costs. The right side shows you that. $304 billion in 2013. Now that's 7 years ago. Think about what it is today, now that we have all these newer meds that are more expensive, newer joint implants that are more expensive, newer ways to treat things. And then the best thing about this slide is the bottom right, which leads back to my philosophy and my mission. I'm gonna read it to you. Physical activity programs may ease pain and reduce costs due to arthritis. It's not may, it's 100%. We know that exercise, activity, moving your joints, getting balanced muscle strength, correcting movement disorders is probably the most effective in terms of cost, efficacy of any treatment out there. So I always encourage exercise, things like yoga, walking. Walking is one of the best things you can do for yourself. So exercise is a way to empower yourself to treat your own arthritis. So let's talk about rheumatoid arthritis. This is going to get heavy into the science, but I think a lot of you are interested in that, so I'm going to do it. Rheumatoid arthritis will affect any joint, really, okay? And that shows you on the left side, spine, knee, hip. Doesn't show you the SI joint, it can affect that, shoulder, wrist, fingers, ankle, really anywhere you see two bones moving together, you can get affected by rheumatoid arthritis. About 41 out of 100,000 people are diagnosed every year. That doesn't mean there's not more out there. And there's about currently 1.3 Americans with known diagnosed RA, rheumatoid arthritis. Higher risk if you're female than if you're male, and it generally starts to present itself somewhere between age 30 and 60 unless you have juvenile rheumatoid arthritis, which is a totally different condition. Next slide. This I put in for a reason. The right side shows you a surgical picture of a tophi being extracted from a joint in the foot. A tophi is sort of a toothpaste-like ball of fluid, I guess, but it's more toothpastey than fluid, which is produced by the synovial lining of a joint when you have rheumatoid arthritis. And so this is one of the problems with rheumatoid arthritis is you produce these painful tophi and they can sort of show up anywhere in the body. The left side just sort of shows you how complex this issue really is. That right thing inside of the joint shows you sort of the damaged lining of the joint that's producing all of these heightened inflammatory activities. And then the goal of treatment of rheumatoid is to calm that down. So pharmaceutical treatment for rheumatoid is pretty important. You've got the DMARDs, which is disease modifying agents. So monotherapy and dual therapy, you could be on one, you could be on two. If you fail that, you go to a DMARD and a tumor necrosis factor inhibitor. Tumor necrosis factor is one of the upregulators of inflammation and damaging of the joints. So we go stepwise, a DMARD 1 or 2, a DMARD plus a TNF inhibitor. Or you could go with a DMARD and methotrexate. Methotrexate's been around forever, highly effective against rheumatoid arthritis. Or you could go to a different biologic agent with or without methotrexate. And then of course you also have adjunctive treatments or sort of the traditional treatments to include steroids like prednisone, Plaquenil, which we've heard a lot about in the news, tramadol, which is a low-grade narcotic, or alternative medications. And then the left slide shows you sort of the prevalence of selected autoimmune disorders, starting from lupus and moving up to RA, and clearly rheumatoid arthritis is one of the more prevalent of these conditions. So what happens with untreated rheumatoid? So when I was training, when I was a resident, we used to see people come in a lot with a hand like the picture here and the rest of their joints looking sort of that way, and just really disabled by this disorder. But I can tell you, since I got out of residency over the past 10, 15 years, you see less and less people like this because of the pharmaceuticals that are available now and the more early diagnoses that are happening. So medicine is continually moving and changing, and we're learning all the time. Science is not a static thing. It is always changing due to experiments and different knowledge, research, et cetera. So that hand is, you don't see that much anymore. Not that it's not out there. I see it still periodically, but it's just certainly not as prevalent. This timeline is a beautiful picture to show you when the damage begins. So you might get rheumatoid, your damage starts year 2. Well, you may be undiagnosed, nobody knows. And then you sort of keep going along. And by the time year 10, and you haven't been treated because it's not been undiagnosed, you're really not able to work at that point because you're so disabled by the arthritis. And then different things will affect the quality or the quantity of the damage of this disease. Genes, genetics or hereditary, your lifestyle, which again goes back to the chronic inflammatory burden of which we spoke, and then your environment. So treatments, again, the pharmaceuticals have changed the game for rheumatoid. Now, there is no cure for osteoarthritis. Rheumatoid, we're getting closer. Much better long-term outcomes, as we've discussed, but these are not without side effects, and they're very, very expensive. So the goal of these treatments, the top slide shows you, is to turn a hot inflammatory cell into a cooler one that's less inflammatory. And that you go through that algorithm that we talked about, from the disease-modifying agents to the tumor necrosis factor inhibitor, so on and so forth. And then the bottom slide sort of shows you the action of each different medicine along the course of inflammatory condition or autoimmune, where your body turns your own inflammatory powers against itself, sort of like friendly fire if you're in the military. Next slide. It's not moving. All right. We're having a technical difficulty. There we go. All right, so this left slide, or the left side of the picture, shows you a survey of different people with rheumatoid arthritis, of what they've tried. Most have tried prescription medications, because sort of as physicians, that's what we do, right? You come see us and we write a prescription. Many have tried over-the-counter medications. Some have tried splints or supports. A lot have tried complementary medicine, which is sort of what we love here if possible: yoga, acupuncture, lifestyle change, nutrition, meditation, biofeedback, things like that. Really, 1/3 of patients with rheumatoid have already tried this. Rehab, which is physical therapy, surgery, and then other modalities. Surgery is on the bottom of that list, thankfully. So the top lists a study here that was done where complementary and alternative medicine is no longer sort of a last resort. Many people go to this first now. Many of these complementary products include ginger, which has a great background on it, great studies to show it reduces pain. Fenugreek, different plant-derived products, more importantly, plant-based diets can reduce the symptoms and the damage of arthritis. Honey can help. Vitamin D, calcium, zinc, all kind of medicines that get your immune system optimized, where you're not necessarily making it stronger and better, because you don't want to attack yourself more if you have an autoimmune, but you want to modify it, modulate it, and control it. Next slide. So there have been studies looking at complementary and alternative or natural medicines, and there's actually great data behind it. The National Institutes of Health looked at omega-3 specifically. I recommend this to people in general for health and wellness and arthritic pain and musculoskeletal. Fatty acids are awesome pain reducers. So the EPAs and DHAs and the omega-3s have been looked at scientifically for RA pain, and they work. Omega-6 also works. A 2000 Cochrane review showed that it was highly effective. Cochrane Review is a group of well-respected experts in each field, and they go through all of the literature periodically, grade the studies, and grade the quality of the evidence, and they'll say whether they think, based on the current available literature, which of course is only the current available literature, whether at that time a treatment is effective or not. Omega-3, omega-6, good. Natural, plant-based, awesome. Seafood, you really get that from fish oil, things like that. You can get it from hemp oil too. Turmeric, ginger, valerian, also shown to be very, very effective. And valerian root will reduce anxiety and help you sleep better as well. Going vegan or focusing on a more Mediterranean diet, which is heavy on seafood, light on chicken, very light on red meat, and heavy on olive oil, which is a great oil to give you appropriate nutrition that you need for good brain, heart health, and joint health. And then yoga. Yoga has been shown in multiple studies to improve quality of life scores. So we have different ways to grade outcomes when we look at a certain intervention. And some of these are physical function scores, some are radiographic scores, some are pain scores. Quality of life scores are probably the most important when it comes to, does a patient have happiness after an intervention? And yoga has been shown to have awesome quality of life scores. So our goal, when we see somebody with RA or OA, we want to make sure you're appropriately treated pharmaceutically if necessary. We want to make sure you have good nutrition. We want to make sure all your other providers are on board with everything, that you've had the appropriate blood work. But really, we want you to be active. We want to correct your movement disorders, and we want you to get out there and get part of life. Play with your grandkids, play with your kids, make dinner, go for long walks, hike if you want. So that is our goal, and we want you to be the couple on the right or the lady on the left. We don't want you sitting on a couch being depressed with pain. That is not what the human body was meant to do. It is meant to be in motion. Use it or lose it is true. So knee arthritis, or OA, osteoarthritis, which is bony arthritis. Some say inflammatory from chronic inflammation. Again, that lifestyle burden. Most is genetic. But is genetic really genetic, or is it really just the lifestyle that you become accustomed to, sort of the culture of your family? Nobody really knows. It's all being looked at. It can result from injury. It can result from infection. Risk factors for arthritis include obesity, and this is not because of the heaviness so much. It's because every fat cell or adipose cell produces inflammatory cytokines all day long, every day, for as long as you have that extra fat cell. So people that have too much adipose tissue are basically inducing inflammation in their own bodies on a daily and constant basis, and that's damaging to joints. Age, we showed you before, as the prevalence of arthritis increases. Repeated stress, so if, like, let's say you have a movement disorder where you have a bow leg, right? You're varus at the knee, and you don't correct that with either a brace or different exercises, stretching the medial hamstrings, tightening the IT band, etc., then you're going to continually overload the medial compartment, and over time, that might impact the cartilage. Women seem to have a bigger effect with arthritis than men, and then bony deformities. So if you have an alignment issue and you load something incorrectly, that'll potentially lead to arthritis.
On the topic, I had rheumatic fever as a child. Is there any correlation with having that and issues with connective tissue?
So we just had a question. Somebody had rheumatic fever as a child, and they want to know if there are any issues with that related to this. So rheumatic fever is a little bit different than rheumatoid arthritis, but rheumatic fever does, in fact, in some people lead to pain and joint disability later in life and will cause some connective tissue disorders. But that's different than rheumatoid arthritis, and I'm not sure the same drugs and treatments will work. Would have to give another talk on that, but it certainly can cause some functional disorders later in life, for sure, including pain. So what do most people do when they're sitting at home kind of Googling and self-treating? RICE, this is what you learned when you played sports. Rest, ice, compression, elevation. So your knee aches, you take a day off, you take a couple days off, you put a little knee sleeve on or an ACE wrap, you ice it, you elevate it. Actually very effective. Most pro athletes do that for their first injury. So I think that's a great first go-to. Over-the-counter medications, Tylenol, ibuprofen, Motrin, more and more things are becoming over the counter. Voltaren gel was prescription about a year ago. This is 1% diclofenac topical, now over the counter. Home exercise programs. These are good, but people have looked at these against physical therapy, and actually a structured formal physical therapy program is more effective than a home exercise program. The home exercise programs that work the best are the ones that are done in conjunction with physical therapy. And I'm not saying you do a home exercise program with 3 times a week PT. You might start with 3 times a week PT, then go to 2 times a week, then go to 1 time a week, and then you're doing a home exercise program, and you're seeing a therapist like once a month maybe, or once every 2 months. Sort of like professional athletes again. They all have their own physical therapists and massage therapists on speed dial. Just because they're feeling good and well doesn't mean they don't go seek preventative treatment, tweak a few things that are wrong, and make sure they're optimized. Same thing should be true for us, I think. Over-the-counter bracing, somewhat effective, but a lot of so for knee arthritis, so we prescribe braces often. Like if you came in and your knee was like this, right? I would give you what's called a medial unloading brace, and it would correct you back the other way to take pressure off of that inside compartment. Those are more prescription-based, and you get measured for them, and they're covered by insurance generally, thankfully still, although they're trying not to. Those are effective. Over-the-counter bracing is plus minus in my opinion, but sometimes the compression sleeves help people feel better. Canes, obviously these work well. Point of fact here for you, if your left knee hurts, you should use the cane in your right hand. Counterintuitive, but the way the physics and the vector forces with weight bearing work and our response to gravity, use it in the opposite hand. Activity modification and avoidance. Okay, this is a treatment that many doctors used to recommend and still do today, unfortunately. Oh, stop running. Oh, don't do that. Oh, you better not do that. Your knee's going to go bad. This is actually probably the worst thing to do, is to stop moving, and probably not a good decision with rare exception. On the topic, we have a question. Somebody asked if any of my Well Theory products help. So I have a company called the Well Theory, which is my natural medicine line, and this talk was not going to be about that, but we do have an awesome pain cream, and it's actually sold on the Healing Soul site, which is where I have my flip-flops for heel pain. That's my favorite topical. And it's on the Well Theory as well. So there's a couple topical creams that work awesome, and we also have CBD, which is an amazing anti-inflammatory and antioxidant. So CBD is more antioxidant than vitamin C or vitamin E. And one of the reasons that we get damage to cartilage from bad diets is oxidative stress, which I don't get into that in this talk, but you basically get these free oxygen molecules that run around looking for a partner to make them a pair of electrons, and they pull that partner from needed items like lipids and different things like that in the cartilage and basically damage the cartilage. So you don't want to have free radicals running around. That's what causes wrinkles and gray hair and damaged joints. So you take antioxidants, of which CBD is one. We have a lot of products for this condition. In fact, we're just coming out with one of my favorites that I take and I've recommended for arthritis and gout for years, which is tart cherry extract. Awesome anti-inflammatory. But anyway, next slide. So when do you talk to a doctor? Because obviously you can almost pretty much treat yourself nowadays with the different apps that are available and Google and whatnot. When the pain is severe and it begins to affect your day-to-day life. So like, let's say you get home from work and you hurt too much to play with your kids, or you hurt too much to even help them with their math homework, or you don't want to make dinner, or if you do make dinner, you're going to do the easiest thing, which is order pizza. When you start to develop instability and altered gait. My mother just had a total knee replacement and she's 77. And she went as long as she could, but she had developed such a bowed knee, and she swims 3 mornings a week, walks all the time, exercises. Her deformity got so great, it changed how she walked and really became a big problem, a big source of pain. So she finally got a total knee replacement and it's worked well for her. We're going to talk about that coming up here. You want to avoid progression. So come see people like me if you want the arthritis to sort of stop where it is and not get worse and get as good as you can get. So basically when you find that your home remedies aren't cutting the mustard anymore. So what do? We take an x-ray, a weight-bearing standing x-ray. Sometimes we'll have you bend your knee when we take the x-ray, and that'll show us where this part of the femur hits the cartilage versus this part of the femur, so it gives us a little bit more information. We might do an MRI. We might do what's called a SPECT CT, which shows actual true biologic bone turnover at sites of problematic arthritis. We'll take a strong history and we'll do a good physical exam. Usually, some doctors don't actually do physical exams anymore, but we try to. What are our treatment choices? Well, sometimes your arthritis isn't that bad, and we do what's called watchful waiting, which is basically come back when it's really bad, but we don't think you need any treatment right now. Physical therapy is an awesome treatment for arthritis, early, late, mid-stage, whatever. Most people have a little bit of a dysfunctional movement disorder from any reason, and physical therapy can really, really help with that. Also, there are different muscles that actually cross the knee joints. So the gastroc or the calf muscles insert here. The hamstrings insert here. The quadricep incorporates both sides of the joint. So if you can make those muscles work better together, you can basically create sort of a hydraulic shock absorber for your knee and also control any instability just from increased muscle strength, targeted increased muscle strength. So physical therapy is a great first-line treatment, midway treatment, and even late treatment for arthritis. I'm a huge fan of physical therapy. Injections, steroids are sort of the traditional thing. This is the go-to. This is what's covered by insurance. This is what everybody says, oh, my friend had a steroid injection and it worked great. Well, okay, but steroids are not without problems. More and more literature is coming out now that is showing us how bad steroids really are. We try not to use steroids unless it's a super last resort in my clinic because of the damaging side effects of steroids. There are alternatives to steroids, but in terms of short-term pain relief, it's a great Band-Aid. And then, of course, medications, prescription medications, all of the biologics we talked about with rheumatoid, and then surgery is your last resort, clearly. Okay, so let's quickly talk about surgery for knee arthritis. And I'm not going to talk about everything. Knee replacement surgery or total knees is obviously the most common one that you hear about. Knee arthroscopy is sort of cleanup procedures. And then there's even surgeries called HTO, which is high tibial osteotomy, where, remember I told you sometimes people are crooked? Well, you can actually cut the bone and shift it instead of using a brace. Next slide. So what about arthroscopy? So a lot of people go see their orthopedic surgeon. You get diagnosed with arthritis and they say, oh, let's do a knee scope, we'll clean it up. Well, okay, well, what is that? Well, basically we stick some metal instruments in your knee. One of them is a rotating basket shaver, and we like remove some damaged little loose bodies, or we trim the meniscus. Well, in 2002, there was a huge sham surgery study at the Veterans Administration. And what this means is they literally put people to sleep One group got an actual surgery, the other group got incisions, and then they woke them up and blinded followed them, meaning that the surgeons that were following the patients didn't know who had what, and then the patients didn't know if they had had the real surgery or the sham surgery. And what they found at the end of this study is that the cleanup procedure did not do better, and in fact probably did worse now that we've learned more about arthritis than the group that had nothing. What about trimming the meniscus or a meniscectomy? Now, back in the 80s, we used to take out the whole meniscus. We figured out that wasn't a great idea. Now we just trim the meniscus. Well, more and more people are finding out that the meniscus, which is sort of the semicircular pieces of gristle inside the knee joint, okay? They are protective of cartilage. They are protective of the knee joint. They provide cushioning, they provide rotational control, and they're needed. You should not have menisci. So we've learned that if you get a partial meniscectomy, your risk of getting arthritis is far greater than if you had not had that partial meniscectomy. So I personally, unless there's a real reason to go in and go after that meniscus, I try not to do these quote unquote cleanup procedures, because at the end of the day, they make the knee worse, believe it or not. Now, in some cases, if your meniscus tear is just right, you can repair it, and that's a different story, and we do that, meniscal repairs, to try to preserve the meniscus. So that's the real goal, but we found that if you get a knee meniscectomy, especially if you're female, your progression to needing that knee replaced is way faster than if you had done nothing, with some exceptions. And again, on the right side, I show you why the meniscus is so important. Stability, making the joint congruent, distributing force appropriately, lubricating the joint, and then giving your body position, which we call proprioception. This is a question, hold on. Okay, somebody just said they've had a couple meniscal tears, they've had a couple HA or Euflexa injections, and they've been told they need a knee replacement. What's the question? Yeah. Okay, yeah, and basically their meniscal procedures in the Euflexa did not work, which we'll talk about, which is probably true. Now, do they have a movement disorder? Is their hamstring too tight? Do they have a poor vastus medialis obliquus and it lets their patella go to the right side? Is their hip stiff? I don't know. There's a million different reasons your knee might hurt that you could correct before you would have to have it replaced. But at a certain point, a la my mom, you do need it replaced. And there are awesome knee surgeons out there that do great work with this. But again, not without issues. So let's talk about it. When medical therapy fails, you will go on to getting a total knee replacement in this country because it's so popular and covered by insurance, and there's so many surgeons that do it. This is when your quote unquote physical functioning falls to unacceptable levels. Now, of course, a lot of that is mind over matter, but at a certain point, you might have to bite the bullet. The goal of treatment of knee replacement, and you can see in the picture, you have the arthritic joint, and then you basically recoat the surface with metal and plastic, okay? So the goal is to reduce pain and to get you more functional. And if you're taking pain pills, to reduce your intake of pain pills and to improve your ability to walk without lurching and limping and things like that. So oftentimes you'll hear this is great surgery. They don't fail. The survival rate or the success rate is 90–95%. Well, when surgeons talk about survival rate or success rate with total joint implants, what we're talking about is that we didn't have to go physically in another surgery and remove it. It doesn't mean it was 100% perfect result, and that's a whole different question. But in general, in this country, if you get a knee replacement and it's done well, you can expect it to last at least 10 years. But there is a significant amount of downtime, and then there's some other issues. Next slide. So again, great surgery, not without risk. This slide on the left is from a great paper that showed all of the reasons for knee failure, and then over time, and when it failed early, meaning within 2 years, or late after 2 years. So loosening, and that's from sort of wearing down the plastic, and then that causes cysts and changes around the implant and makes it loose. That's a primary reason for revision. Infection is a big deal, and another reason for a revision. Instability, or it was put in a little bit too crooked, and then you have overload on one side and clicking and pain, and you have to get it straightened out in a revision, the third biggest reason, so on and so forth down the line. So there are a number of reasons that these things don't work well. If you think about it, even though it's a great surgery with a 90% survival rate, you're replacing a beautiful, natural, sort of functioning joint, even though it's damaged with metal and plastic. It does work well, but you need to keep that in mind and go in open-minded and know it may not be sort of the perfect result you're expecting. So just have good expectation management if you're about to get a total knee. Ranges, the poor outcome ranges, meaning people that aren't happy or have issues with their knee replacement, even though they don't get it removed, ranges from 7 to 20%. So fully 1 in 5 people aren't happy at the end of the day. That's why we try to make it a last resort. Okay, we're going to talk about non-surgical treatments now. Physical therapy, acupuncture, HA injections, stem cell therapy. I'm not going to get into that too much in this talk. That'll be another talk. PRP, I will talk about that. Natural pain relief, and then prescription pain relief. So we talk about physical therapy, dry needling, stretching, working on your movement disorder. Yoga. Now, the things on the right is this guy's obviously a professional, and we're not going to ask that of anybody. The left side is more what we're talking about, but we can get you to the right side starting on the left side. Basically, we can create and develop, and I work with the Peyton Fisher Yoga Company, and we're working on different protocols for different people with different movement disorders to make a yoga program. So hopefully we can get you on the right side, although even I can't do that, certainly. But yoga is just so awesome for the human body. I can't emphasize it enough, so big fan. Next slide. Natural pain relief. We talked about omega-3, omega-6. That works great for inflammatory arthritis, of which osteoarthritis is one. We talked about the products on the right, the Well Theory products. One of the biggest ways you can treat your pain is weight loss and diet change. Got plenty of patients that went gluten-free, and all of a sudden their inflammatory burden dropped, pain went away. Patients that have gone vegan, pain went away, stop taking medicines. Diet has a huge role to play here, and it's poo-pooed, and a lot of people push it off, and they don't really think about it and take it seriously, but it is massively important what you eat. So just like a computer, the data you put in the computer is going to change the data that's spit out. What you put in your body is going to change what your body gives out. Topical pain creams, low impact activities. Okay, so I'm not talking about don't go do CrossFit or start doing Krav Maga and other martial arts like that. I'm talking about Tai Chi, yoga, walking, swimming, cycling. All of these are awesome exercises that reduce pain and disability of arthritis. Okay, somebody had asked earlier about Euflexa. Euflexa is just one brand of hyaluronic acids. There's Synvisc, there's Orthovisc, there's Monovisc. There's a million of these. Unfortunately, nowadays, most insurance companies don't pay for these. So it's a series of 3 injections, and the out-of-pocket cost ranges from $300 to $600 per injection. So generally not covered anymore. Basically, hyaluronic acid, you know, it's the same HA almost that you put in your face for fillers, and women put in their lips. You can get a slightly different formula, higher molecular weight, and you put it in your knee joint. And it increases the viscosity of the joint fluid, makes it cushion, load better. It's anti-inflammatory, and it basically gives nutrition to the cartilage. But again, not really covered anymore, so we can't really offer that too much. Corticosteroids, cheap, covered all day long by insurance companies. Terrible outcomes, will increase your risk of infection if you have a total knee, even if you've had a steroid injection within a year of getting that total knee replacement. It's an effective short-term Band-Aid, but the long-term results are not that great. And again, as I said before, I think the side effects often don't make it worth it. But if you're already bone on bone and you just don't want to get a total knee replacement yet, maybe you can do it. But if you're thinking of getting a total knee within the next 6 months to a year, I would not have a steroid injection because your risk of infection is higher after that. And we talk about that on the right side of the slide. 2 weeks of improvement is typical, and people have studied the results of steroid over years. 2 weeks of improvement for a steroid injection that could potentially damage the cartilage and cause you problems later with other surgeries. I don't know if that's worth it. And if you're diabetic, it can spike your blood sugar. Higher doses are needed to give you a longer duration of treatment. Or there's these new formulations that are steroid in these like little lipid packets that let the steroid out over time. So you're basically giving yourself dosing of steroid over time. Have yet to see long-term outcomes as to the damage to knee joints from that, but that'll give you a little bit of longer-term pain relief. That is an option. And interestingly, studies have shown that up to 20% of injections don't even make it into the knee. So if a surgeon or a rheumatologist, whoever's doing your knee injection, doesn't have a clear and deep understanding of the anatomy, they'll miss the knee and you'll never know it. Next slide. So PRP, this is one of my favorite treatments. Now let's talk about that. Platelet-rich plasma. So platelet-rich plasma, or PRP, is actually made from your own blood. So it's fully natural. No risk of contamination or adulteration from an alternative source, okay? It's not made in a factory and sent to you by a pharmaceutical company. This is your own blood that we process in clinic by centrifuging it, which is spinning it around very, very quickly, and that'll actually separate the red cell layer from the white cell layer, and you can see that in this picture. So the red cell layer will drop to the bottom, and the white cell layer goes to the top. And what that does is it lets us put into your knee, where your arthritis is, and various other body parts for different problems, a very concentrated amount of platelets. So let's say you had 100 platelets per cc in your normal blood. We would be able to put in 300 or 800 platelets per cc into your knee joint. And then once you put this in the target tissue, you're basically dropping a massive load of healing into that area. This is not covered by insurance either, but this is a go-to treatment for most celebrities and pro athletes, and it is highly effective, and more studies are coming out showing that. The prices will range anywhere from $150 to $5,000, depending on where you live. But again, it's really not much more expensive than HA and way more effective. This left side, I just put it in here to show you the complexity of what these platelets release. So in the platelets are what are called alpha granules. They're little packets that in the normal course of things, you get injured, the platelet comes, the little packet goes to the edge of the platelet, it opens up, and it releases all of these pro-healing cytokines, anti-inflammatory cytokines. And so it'll bring in different substances that form new blood cells to promote healing. It'll kick out the bad macrophages, bring in good macrophages. PRP just basically advances in a concentrated manner all of the immune healing capacity of your body. I love it. It's a natural way to sort of catalyze or kickstart your own body's power. So people have looked at hyaluronic acid or Euflexa, as a person asked about before, and I don't know if the study was Euflexa, it could have been Synvis, versus PRP. This is from the American Journal of Sports Medicine, and about 3 years ago, they looked at 111 patients. They found that there was no difference in outcomes, meaning that they had similar pain scores at the end and function scores, but they also looked at the internal structure, if you will, of the joint fluid, and they found fewer inflammatory cytokines with PRP. What does that mean? Over time, your arthritis is going to progress less if you get PRP versus HA. A more recent study with more patients looked at HA versus PRP, and they found that the relief at 9 months, you had relief for 9 months, with HA, but up to 12 months at least with the PRP. And there was less re-intervention with the PRP group. What does that mean? You didn't have to do another injection. You didn't have to go have surgery. So the PRP group, it was get the PRP, and most of them were done and treated and the pain went away. The HA group did not have as much success. Oh, we got questions. Hold on.
Where are the PRP injections inserted for knee arthritis, in the cartilage or the bloodstream? What's the goal? Does it rebuild the cartilage?
Okay. They want to know where you put PRP when you're treating arthritis. Do you put it directly in the knee, or do you inject it into the blood? You take it from the blood, process it, and inject it into the knee. So we take your blood, concentrate your platelets, and inject the platelets into your knee joint. And then the platelet alpha granules release their magic inside your knee and actually will slow down the progression of arthritis and help your cartilage heal. Because one of the things PRP does, some of the proteins those alpha granules release will actually send autocrine, or sort of like hormone type signals, out in your body and pull in stem cells. So it's sort of the poor man's way of stem cell treatment, if you will. You get PRP, and whatever stem cells you have left, you can draw them in. And that's really the only thing that could ever grow cartilage back. As I said, there's no cure for arthritis.
So then the follow-up to these questions is, which helps more with regrowth, PRP or stem cells?
So which helps more with regrowth, PRP or stem cells? Still an open question. We're looking at it. There's a lot of literature in animal studies, particularly in racing horses. Stem cells seem to be winning this game right now, because you put stem cells back into the knee joint, and they not immediately, but they turn into chondrocytes, or at least they make all of the quiet chondrocytes, meaning cartilage forming cells inside your knee joint, turn on and become active, productive cartilage forming cells, which normally in cartilage, none of them are working. Nothing's making new cartilage on a given basis, but you drop stem cells in and you can sort of turn them on and make it happen. So stem cells seem to be better at growing new cartilage and growing new meniscal tissue, but PRP is helpful. It's way more affordable. It's way easier to do. And again, if you're not 80, If you're not 70, you could get PRP. There still should be some stem cells in the region that you can draw in just with the PRP. Okay, thank you, Vicki. That was Vicki's question. All right, next slide. Wait, you skipped a slide. Okay, sorry. Again, left side showing a little bit more complexity of how this works, but it's pretty awesome. And I put this slide in to show you, I don't know if you remember when we talked about rheumatoid, with all the different autoimmune things, the attacking cells or attacking molecules like tumor necrosis factor and IL-1, different things like that. Well, PRP can downregulate those too, just like those high-grade pharmaceuticals that are made in factories do, the DMARDs and the methotrexates. PRP is just a much more natural way to do this. Not that I'm saying it's a treatment for RA, although there are great studies out there with people looking at this. In fact, in rheumatology in 2016, this is a study out of Brazil, they looked at all the studies of PRP for knee arthritis at that time that met their criteria of what they considered a good study. They ended up with 23 studies, and they found that there were improvements in pain and function when you looked at PRP versus hyaluronic acid or PRP versus nothing. And this response lasts up to 2 years. So when you get HA, it used to be we did it every 6 months. Well, again, now it's not covered. But PRP, you could get done 1 or 2 PRP injections, and then that lasts 2 years in this study, that's pretty awesome. So how many injections are needed? That's an open question still. Many studies are done with a single injection, but probably the sweet spot is 2. My practice, we do an injection. We expect the PRP to evolve over about 6 weeks, that healing cascade, and then you won't really know your full result for a few months. But if somewhere between that 4 and 6 week point, you have some improvement, but you're not exactly where you want to be, those are the people that might benefit from a second injection. If you have no improvement, we probably say it's not going to work for you and we go on to a different treatment. And if you have awesome improvement and you're doing great, then we don't have you do that second injection because we don't want to put that expense and burden on you if we don't have to. So 1 to 2 is about right, I think, for PRP. And the same is for facial. So the vampire facials and different things you do to increase the collagen growth in your face, it's generally 1 to 2, sometimes 3. Maintenance, you might have to come back once a year or once every 2 years, as this study showed. When a lot of people get it done for baldness, which we do for people sometimes, because PRP makes hair grow more too, usually you get a series, like 3 or 4 maybe, and then you just do it once a year. So yeah, there is some maintenance involved, but now that we're getting more effective with how we do the PRP, like how we spin it and the levels we put in, I think you can probably get 1 to 2 years out of this. Are stem cell transplants still considered experimental was a question. Certainly by insurance companies, because as long as they can consider it experimental, they don't have to pay for it. But stem cell transplants for knee arthritis and things like that are used heavily and extensively in this country and are very, very effective. It's just unfortunately you have to pay cash for it or use a health savings account because to date, the insurance companies won't pay for it. So again, that's PRP going into a knee. We can use an ultrasound, which we have in my clinic, to target it. So like if I'm doing tennis elbow PRP, I look right at the extensor carpi radialis brevis and watch the injections go into that tendon. Same thing with Achilles tendonitis, tibialis. So you can watch it go in the knee joint. Remember I told you 20% don't go in there. So if your physician's not super confident or highly successful with non-imaged injections, you can use an ultrasound, which we do sometimes just to make sure we get it where we want it in different tendons and different structures. I've done PRP for rotator cuffs, and in that case, I'll definitely image it because you want to hit where the partial tear is. And we've done PRP for meniscal tears, and again, you want to target it next to that meniscus. So we use sterile technique. It's done in the office. We have all the equipment here, minimally invasive, a single blood draw. We draw your blood out and then we process it in the centrifuge as described, and then basically inject it where it needs to go. We just ask that you stay off of any anti-platelet or anti-inflammatory medicines for a week before the procedure and 2 weeks after the procedure, or you're basically negating the quality of the procedure. Next slide. So when is PRP effective? Does it work for all arthritis? Well, in short, yes, but it's best for early arthritis. This shows you the progression of arthritis, okay? Stage 1, maybe you've got arthritis, maybe not. We would have to do a highly specific cartilage targeted sequence on MRI to really tell you if you do or not. Stage 2, it's a little bit more obvious. Stage 3, now we're starting to be like, well, obviously you have arthritis, and stage 4 is when you're bone on bone. Stage 3 down, ideally stage 1 or 2 is when PRP is the most effective and will give you the most long-term benefit, because obviously if you can stop arthritis from progressing past stage 2, you might never need anything else done except PRP every year or 2, which is amazing if you think about it. 3, it might not help. It might buy you some time, like 5-10 years if you're doing everything else, you know, eating a little bit better, if you smoke, if you quit smoking, and if you start exercising and doing low impact motion-based movements and correct any movement disorders. And then stage 4, it might buy you some time, some pain relief, just like HA, just like steroids, but much more natural and will optimize outcomes versus de-optimize them like steroids. Next slide. All right, the biology, so let's talk about that. This is my favorite thing. I'm not going to belabor the point, but basically the growth factors and the anti-inflammatory power of platelet-rich plasma is pretty awesome. You get TGF-beta, which is very good for the knee joint, if you will, sort of a growth factor. Insulin-like growth factor 1, which is a proxy for growth hormone. So a lot of us lose growth hormone as we age, and so you lose muscle mass, you increase fat mass, your bone quality goes down, your musculoskeletal health goes down. Well, PRP upregulates insulin-like growth factor and gets you sort of healthier. Bone morphogenic protein, this is great. Substance, and bone morphogenic protein will turn on or off bone forming and cartilage forming cells. So again, remember I told you the chondrocytes get turned on and start making cartilage. This is one of the reasons why. Or platelet derived growth factor, another thing out of the alpha granules, is very pro-healing, anti-inflammatory, pro-growth, and the list goes on and on. So TGF-beta in specific will induce chondrogenic differentiation, meaning if you have a quiet stem cell sitting in your knee joint, or you have stem cells in the surrounding area, they'll come in, it'll turn it on and make it a cartilage forming cell. And it will antagonize the damaging effects of any pro-inflammatory interleukins like IL-1. We talked about insulin-like growth factor a bit, and then platelet-derived growth factor also assists in the regeneration of articular cartilage. And there are some pharmaceutical products on the market that are just PDGF, made in a lab and used for wound healing and regenerative different substances and different applications for medicine and surgery, but you can get it from your own blood if you do PRP. So I don't know if anybody knows about the Hospital for Special Surgery, but this is the premier musculoskeletal hospital out of Manhattan, and a lot of pioneering work is done there, and they looked at PRP recently, and they found that in the group that got PRP in this study, 73% of them delayed the progression of arthritis. In other words, the group that did not get PRP, their arthritis got worse. The group that did get PRP did not. So they followed 15 patients for a year, and they did MRI studies. And this facility or hospital has one of the premier MSK radiology groups in the world, and they have pioneered the development of cartilage-specific sequences. So their MRIs are good, and they know what they're talking about, and they looked at clinical outcomes. Most people that get arthritis, like once you're diagnosed with it, you can expect to lose 5% of the collagen mass or the cartilage every year. Just like as we age, you lose 1% of the collagen in your face every year. So the goal of anti-aging or optimal aging and treating arthritis is to prevent that loss, at least, if not add to it. So the majority of people that got PRP did not have that 5% loss annually, which, think about it, that's what puts you in the group of needing the total knee replacement that we talked about. So if you can just hold your own, if you're stage 1, 2, or 3, then that's an awesome result in my opinion. Pain was down 56%, functional scores improved 24%, and activities of daily living improved 55%. Those are great numbers when you compare it to other scientific studies. And that's just harnessing your own body's natural healing powers and putting it back into yourself. So I think PRP should be a first choice treatment for arthritis. And this is actually out of a study from HSS where they also believe that. Next slide. The question was, when you do PRP, do you do both knees or only the affected knee? I would say if you had one knee that was asymptomatic with no arthritis, I would certainly put it all on the bad knee. If you had arthritis in both knees, but only one hurt at the time, if we could get enough PRP in that blood draw that we could split it, we split it for people. It depends.
And then Charles, he said you made the candidate for PRP for knee arthritis, but what about for tarsal tunnel in the ankle? Do you do PRP there?
I had a question from a Charles asking if PRP would work for tarsal tunnel. So tarsal tunnel is a nerve compression or a nerve entrapment, just like carpal tunnel in the hand. PRP would probably not work for that unless it just simply reduced the inflammation around the region, but it's not going to change the compression of the nerve. You have to decompress the nerve, or alternatively, if you have a nerve, right, let's say my forearm is a nerve and you have a point of compression, if you can just loosen up the nerve, right, under that point of compression, it becomes less painful. So we always try physical therapy first with nerve glides and nerve flossing techniques. If that fails, you have to go in surgically and decompress the nerve. So PRP is not going to do that. The only thing it might do is reduce inflammation in the region, but it's awesome for arthritis and tendonitis. Okay, so in summary, osteoarthritis and rheumatoid arthritis are the leading causes of pain and disability in this country, and indeed in most Western countries. Knee arthritis is massively common. It's going to be one of the most common surgeries performed. Total knee is, again, very, very common. I mean, just the numbers are astronomical. Arthritis is an inflammatory condition, and it's progressive damage of the joint surface coating, the cartilage, usually caused by lifestyle, environmental toxins, bad food, smoking, things like that, and genetics. So a lot of that is modifiable, and we can empower you to make that better. And treatment of arthritis in this country today is just symptom management. Again, I said there's no cure. So for like RA, you take all of these disease-modifying biologic agents. Some people change their diet. Some people start exercising more, and those are all great and will make the symptoms less meaningful, which of course means it doesn't need to be treated at that point, right? But the only current cure for arthritis is to get the cartilage to regrow, which the only thing we've seen evidence of doing that is stem cells and PRP, mostly in animal studies at this point, but we're looking at it more and more in human studies. And it's super safe. I mean, there's really no downside to platelet-rich plasma injections except that insurance won't cover it. And alternative and natural treatments are extremely popular. Again, remember I told you fully 1 out of 3 are already doing it nationally and are very effective for symptom management. And again, they're natural, so they're safe. So to date, nobody's been known to die from a natural herbal remedy as opposed to the massive numbers of deaths from pharmaceuticals every year. So we're big fans of alternative and natural therapies. We're big fans of empowering you to treat your own arthritis. And then if we can, we will harness your body's power and help you use it. PRP is one of the best ways to do this. So any more questions? And otherwise, we'll let you go about your business. That's it. I'll give you a couple seconds here if anybody has any good questions. So PRP doesn't take very long. That's probably a question a lot of you have. It's a same-day treatment. We do it in office. It really takes about 45 minutes all in for the full treatment. And there's really no limits after that, although I do ask that for the first week after you do the PRP injection that, like, let's say you're a big runner, that you don't go for long runs, or let's say you're a power lifter. I don't want you doing your max reps, okay? Because that first phase of healing, the inflammatory phase of healing, which PRP induces, it'll actually semi-weaken tissue, and you don't want to disrupt the tissue during that first phase. So you really don't change your activities a whole lot, but you will want to back off a little bit after the PRP treatment. So hopefully that answers all of your questions, and we're here for you anytime that you want to come by and talk about it more. And have a great day.